Thanks so much for inviting me today. Sorry I couldn't be there in person. So I'm going to be talking about, as was said, RSV. So I'm going to be looking at economic evaluation of potential maternal RSV vaccination strategies and doing a bit of a review of the literature for high-income countries. And as I said, I'm Anthony Newall from the UNSW Sydney. So I suppose most people here probably are pretty familiar with RSV, but it's just a little bit of background. It's a common respiratory infection. It can lead to severe respiratory illness, particularly in infants and the elderly. And there's been a lot of quite exciting developments in RSV prevention in the recent period, including the approval in some settings for certain groups of RSV vaccines for older adults, long-acting RSV MABs, and a maternal RSV vaccine, which has been approved in some settings. So there's a link at the bottom there to the approval for the US. And that's what I'm going to be talking about today, the maternal vaccine. So the aim of the maternal vaccine is really to provide additional protection to young infants. So the vaccine that I'm talking about showed an efficacy of 51.3% against medically attended RSV, lower respiratory tract infections, and 69.4% against severe medically attended RSV, lower respiratory tract infections. And these are the results for within 180 days from birth. So there's different results reported in the clinical trial depending on the period. So over shorter periods, it has a different efficacy, but this is the sort of results over that sort of approximately 6-month period. There's also the potential that it may offer some level of herd protection to other individuals, and that's something that's explored in some of the economic evaluations. So I guess we're sort of now all familiar with herd protection and, with the recent events around COVID, but I guess in this instance, one of the ways it might offer herd protection is by the protection potentially offered to vaccinated mothers. And then if the mothers are protected, they're interacting with other people, but they're less likely to transmit that infection to other people. And so there's some kind of herd effect on the population overall. And as we'll talk about, even relatively small herd effects can be influential in terms of the cost effectiveness. So in terms of the economic evaluation of maternal RSV vaccination, we looked at what had been done up till September 2023. So it was a sort of non-systematic search. We identified 5 published economic evaluations of maternal RSV vaccination. This is just in high-income countries. I guess there's probably many more publications either on the way or that have already been published since that time, because it's such a important and timely topic. So the studies that we identified are listed there. There was a study of 6 European countries, a study in Norway, Canada, and then 2 in England. And the bottom study there by Cromer et al. I was a co-author on, and that was sort of one of the first studies to look at potential maternal vaccination. These studies were all published before, or were conducted at least before the phase 3 clinical trial data was available. And so they had to make various assumptions when they're looking at the potential cost effectiveness around efficacy and so on. And I'll talk about that in a moment. So when you're exploring the cost effectiveness, obviously we do this to look at the value for money offered by different vaccination strategies to try to ensure that if we're funding a vaccination strategy, it provides us bang for our buck compared to other ways we could spend our money. And in terms of vaccination strategies, there's often 2 different types of models that are discussed. So there's a dynamic model and a static model. And really the difference between the 2 is the dynamic model allow you to simulate herd protection effects. So dynamic models are trying to predict potential herd effects on the wider population from things like vaccination strategies. And these dynamic models, were obviously widely used during COVID, so people are kind of more familiar with them these days. And in terms of the studies that we looked at, 3 of the studies used a static model, and 2 used this type of dynamic modeling approach, which was able to predict potential herd effects. I guess of interest was that Hodgson et al. Results suggested that maternal vaccination may result in a small, but what could be an important herd effect in terms of the cost effectiveness of the program. And so that's something that I guess is an argument in favor of looking at the dynamic model, using a dynamic model when exploring the cost effectiveness of this type of vaccine. So there was a number of influential parameters, which are sort of the input values into these economic models that are trying to predict the cost effectiveness. And 3 commonly cited that sort of seem to be fairly consistently cited across the 5 studies that were identified were vaccine efficacy, and I guess that's not unexpected, but now this is known with more certainty than in the evaluations. So these evaluations use a variety of efficacy estimates, most frequently 70% in base case, which I guess is not so far from some of the estimates from the clinical trial. Another one which was found to be important was duration of protection. So this also makes sense when you think about it. It's not just the efficacy, it's important when you're looking at a vaccine like this and many vaccines, it's the period over which it offers protection. And this is important because the risk of severe disease in infants, remains high for some time. And so if you're able to offer continued protection, then that can be really beneficial in terms of protecting the infant, but also to the cost effectiveness of the program. And of course, vaccine price. This was very important, and it was unknown in the settings that were looked at in this study. So they made various assumptions, and most of the studies kind of explored many different vaccine prices and looked at what would the vaccine have to be priced, how would the vaccine have to be priced for a program to be cost effective. And it sort of remains unknown in many settings as well, I guess. But in the US, the CDC, there's a CDC website which provides the US CDC cost, which I give below, and that is listed at $227.15 per dose. So one of the things that was explored in these economic evaluations was seasonal versus year-round vaccination programs. So RSV infections, like a lot of respiratory infections, show a seasonal pattern, and this can differ from setting to setting. And several of the economic evaluations suggested that seasonal vaccination programs were the most cost-effective option when compared to year-round vaccination. And I guess the reason for that is that babies that are born at a certain time of year are at higher risk relative to other times of year of RSV infection, and therefore severe RSV infection, because they're more likely to get infected. They're more likely to be hospitalized. Although the risk of hospitalization is, upon infection may not differ, but because they're more likely to be infected in general, there's a higher risk to infants born in certain parts of the year. So when you compare that to year-round vaccination, which includes vaccine for children who are born over the entire period, includes vaccination, maternal vaccination, and therefore protection to children born throughout the entire year, it may appear less cost effective. I guess obviously the downside to that is that if you're only doing a seasonal program, then even children born in other times of the year who are still at some risk of RSV may not be protected from it. And so there's a trade-off there. But these sort of more targeted programs were found to be more cost effective in certain of the studies. And I guess a question maybe could be a discussion point is we had a look into whether RSV seasonality seems less pronounced in Australia compared to some other settings, but I'd be very interested to hear other people's views on this. I guess in colder climates, it seemed to us that in some colder climates anyway, RSV was more seasonal than in Australia overall. And I guess that might argue for a year-round program if it was to be implemented here. So some other important considerations. So there's some of the economic evaluations looked at the potential to offer protection against recurrent wheezing or asthma from RSV infection. And I guess there's some level of uncertainty around RSV's role in these conditions, but there appears to be evidence coming out around it. So this was considered in 2 of the economic evaluations, and I guess could potentially be important because this sort of costs and effects from these can go on for some time, obviously. Another thing that is important to consider, that could be important to consider, is the comparison between different potential protection strategies. As we said, there's these things like these long-acting MABs, which could be interesting to compare. Some of the models did compare against multiple different strategies. And these could be influential. For example, if the alternatives be considered a less costly or provide better value for money than maternal vaccination, then the inclusion for them when you're comparing between the value for money of different options could potentially be important. So there's not really an easy answer with these things, I guess, like a lot of research, but particularly at this stage. So there is the potential for RSV vaccines to be cost effective in high income settings. But this obviously depends on several factors. And when the time that these studies were conducted, a lot was unknown. And they did do sort of extensive sensitivity analyses to look at which were the important variables and how the cost effectiveness may change depending on how they vary them. But ultimately, if there's a lot of uncertainty, you can't say things with certainty. But particularly things like the vaccine price can make an important difference to whether something is cost effective. And in this case, that was predicted in the economic evaluations. And generally, economic evaluations are not seen as transferable between settings because there's differences between settings, between countries in terms of healthcare costs and the epidemiology and things like that. So that just because a vaccine may be cost effective in the US, for example, doesn't necessarily mean that it'll be cost effective in Australia. And usually we try to conduct economic evaluations in this setting-specific economic evaluations. So for Australia, there's obviously further research is needed to establish the cost effectiveness of different RSV prevention strategies. This is something that we're working on or have been working on, and hopefully we'll be able to present in more detail soon. I'd just like to acknowledge a PhD student who recently graduated who helped to identify and review the economic evaluation cited. And these are the studies that were identified that we looked at. Thank you very much.
Anthony, thank you. On your last point, there is an online question as to whether or not there'll be any economic studies on RSV vaccination in older Australians, particularly given that the vaccine is likely to become available very soon.
Yeah, so that's another really important group who hopefully will be looked at in more detail. We're not looking at it at the moment, but I'm sure that some groups will look at it in the future. I guess in order to get funded in Australia, typically an economic evaluation is needed to sort of as part of the PBAC process to get on the national immunisation program, but also often these sort of evaluations done by academic groups such as ours, and it may be something that we look at in the future.
Thank you. Are there any other questions or comments? Anthony will be online for the panel discussion. David.
Thanks, Tony. A couple of things. One is that obviously you commented on RSV seasonality, which certainly pre-COVID was extremely tight, at least in the southern half of the country, and just like flu, there was a bit. You can get a bit of a summer season as well, but I mean, certainly we've had very tight seasonality, and it's going back to that pattern now. So it should make that decisions about when you deliver the vaccine a little easier, hopefully. But the other thing is, do you factor in, because they're looking at rolling out the monoclonal antibodies for prophylaxis in infants and deliver them as extensive programs, do you take potential cost savings of that therapy into your modelling of the cost effectiveness of maternal vaccination?
Yeah, so they the studies that have been published, some of them looked at these different strategies, and I guess what they do is what they tended to do was look at either compare the strategies. So what's the cost effectiveness of maternal vaccination? What's the cost effectiveness of giving these long-lasting MABs? Or you could potentially give the MABs to certain groups and then also have a maternal vaccination program. But obviously, if you're doing both programs, then if you're preventing a lot of the disease by one of them, then there's sort of less disease there to be prevented by the other, and so it can become less cost effective to do both. So it may be what these studies kind of looked at partly was which is the most cost effective strategy, or combination of strategies. And I guess a lot of it does come down, an important part at least, is the price associated with the different strategies. So I think that's probably likely to be pretty important based on the studies that are reviewed.
Thank you, Anthony. There's one more question, and it might be outside your expertise, but I think there's phone a friend in the room. I think the question is, why has it taken so long to develop an effective RSV vaccine?
Yes, that might be probably there's many people there better qualified to answer that question than me. But I know it has been a very long journey with some bumps in the road. But yeah, I might leave that to others to comment on, because there's I'm sure people better qualified than myself to answer that.
Would anyone in the audience like to give a quick answer? Thanks, Cantor.
So I think the biggest hurdle has been the fact that all of the earlier vaccines used the post-fusion form of the F, and the fact that the crystal structure was solved for the pre-fusion F, and then the big advances were in being able to present the antigen in its pre-fusion form. I think that's really been the huge change.
And a great example of Stanley's point of the way we're progressing with time and how every disease creates an opportunity.